you for joining our session today, and in the HIV epidemic through a health equity lens. My name is Alberto Pina, and I'm co-presenting with Michelle Sandoval Rosario. We are with Prevention Through Active Community Engagement program, PACE in Region 9. Our program sits within the Office of Infectious Disease and HIV/AIDS Policy under the Office of the Assistant Secretary for Health, OASH. Next slide. In today's presentation, we will be describing the burden of HIV in the U.S. and the communities most impacted. We will also be describing the Ending the HIV Epidemic EHE initiative and national strategies, discuss federal response to address HIV inequalities to end HIV, and identify ways to address HIV inequalities. We have a few polling questions for folks. Next slide.
All right, so I'll go ahead and pull up the first one.
Okay, am I familiar with Ending the HIV Epidemic in the U.S. initiative? Okay, so 33% are familiar and 67% are not. Okay, next question. Question 2. Hispanic Latinos account for blank percentage of the US population, yet account for blank of new HIV diagnoses in 2019. Okay, we have about half and half here currently. Correct answer is Hispanic Latinos account for 18% of the US population, yet account for 29% of new HIV diagnoses in 2019. Okay, next question.
One second, it's coming up right now. Actually, maybe it's not. So if you can go ahead and just ask the question.
Yeah, thank you. So our last question is treating a person living with HIV, treating a person with HIV with antivirals medication is one method of preventing new HIV transmission. True, false, and I don't know. The answer is true. Okay, next slide. Okay, so to continue our presentation, looking at HIV in the United States, of the 1.2 million living with HIV in the United States, we know that only about 56% are virally suppressed. And those that are virally suppressed are linked to care successfully and are successfully taking their medication. We also know that we still have over 36,000 new transmissions in the United States. And we have plateaued at that number for many years and have not been able to move the needle forward. If we continue to do what we are doing today, we will have another 400,000 new transmissions within the next 10 years. Of those new transmissions, we also know that given the prevention tools we have, not everyone is benefiting from those tools. So we need to do something, and that something was Ending the HIV Epidemic initiative. Let's now look at the burden of HIV in the United States and the populations most affected. Next slide. There are many inequalities in the number of HIV cases across the US. This slide breaks down the number of new infections across different racial and ethnic groups. We can see from the slide that those most impacted by HIV are Black, African American, which is represented by the purple line, and our Hispanic Latinx community, represented by the turquoise line. Next slide. So what does HIV look like across the country? Well, in 2018 alone, there were close to 38,000 new infections in the US. From the graph, we can see that the most infections are among African Americans and Hispanic Latinos. African Americans accounted for 42% of HIV diagnoses, and Hispanic Latinos accounted for 27%. The burden of HIV is predominantly in the South at 52% and 20% in the western part of the US. So if we look at the map, we know that there are disparities not only across racial and ethnic groups, but also geographic areas. Geographically, there are areas that are more rural or urban in this country, with differences in social and economic status. Next slide. Taking a deeper dive now, and if we look at this map, the darker the colors on this map indicates the higher the rates of HIV infection in our states among adults and adolescents. Arizona, California, Nevada are the darkest in the western part of the country. We can consider Arizona, California, Nevada like one state because people tend to come and go between these states. As we saw from the national slides, there are disparities across different groups. It's important for us to think about how we characterize and look at those communities most impacted. Looking at Arizona on this map, we can see a darker coloring indicating higher rates of HIV. In fact, it's the highest rate in the West. Next slide. This is from the Arizona Department of Health Services surveillance dashboard. In the state of Arizona, we can see transmissions occurring specifically among MSM community, among young Hispanic Latinos, ages 25 through 29. Next slide. Although HIV infections continue to occur in the country, particularly affecting communities of color, they really shouldn't. Today, we have the data, prevention, and treatment tools to end HIV. In 2019, under the previous administration, the Ending HIV initiative was launched. This national initiative is about using the tools we have to reduce new HIV infections in the next 5 years by 75% and by at least 90% in the next 10 years. What does this all mean? This means that within 10 years, we want 3,000 or less HIV transmissions in the US. It is a focused effort geographically on 48 counties. Maricopa is one of those counties. It also includes DC and San Juan, Puerto Rico, which account for more than 50% of new transmissions in the US. And we also are focused on 7 rural states with the most of the substantial HIV diagnosis in rural areas. The Healthy Human Services wide plan really focused on agencies you see listed on the right side of the slide. Apologies. To play a key part in moving the initiative forward, we have direct funding from Congress that is coordinated through the Office of the Assistant Secretary for Health to implement Ending the HIV initiative and coordinate activities happening at the federal level. Next slide. On this slide here is just a snippet of the Maricopa County Ending the HIV epidemic. As I mentioned, they are one of the counties that has been identified, one of the 48 counties that has been identified with having a burden of HIV. I encourage all of you to look at this plan post-conference when you have time. Next slide. In addition to the overall goals, the initiative sits on what we call 4 pillars or strategies. The first is diagnose all people with HIV as early as possible. This is an opportunity for us to think about where testing is not only available, but also where can we have HIV testing more available in non-traditional settings, such as emergency rooms, jails, and churches. HIV testing is our gateway to either prevention or treatment services. It is an important component and a very important pillar, which is why it's the first pillar of ending the HIV epidemic. Another thing to think about is that studies have shown that sometimes even STI clinics, individuals who show up with chlamydia might not be offered an HIV test. And this has been shown to be very prevalent among African American women, where they are not offered an HIV test and within a year are HIV positive as a result. So we have to think about not only how can we expand HIV testing, but also how do we capitalize on some of these missed opportunities when it comes to HIV testing as well. The second pillar is treat. Treat those people living with HIV, making sure we can link them to care within 30 days, because what we know today is that the earlier and the sooner we get someone connected into care and get them virally suppressed, the greater the health outcomes. HIV is no longer a death sentence. We know that HIV treatment prevents transmission. There is HIV medication that is taken daily that can virally suppress the virus and not be sexually transmitted from someone that is HIV positive. The third pillar is prevent new HIV transmissions by using our entire HIV prevention toolbox. That not only means condoms, but also means pre-exposure prophylaxis, known as PrEP, a one-day pill that can be taken to prevent HIV by 99%. Other prevention tools are behavioral change, harm reduction, and syringe service programs, which the science has shown can be a huge impact. The fourth pillar is responding using our surveillance mechanisms to be able to identify clusters in HIV in geographical areas. An example, the Mohawk County, which borders Arizona and Nevada, was identified by CDC as a potential region for HIV outbreak. It is an area that is rural, poor, and white with many disparities. In the event of an outbreak, we can bring in both our prevention toolbox as well as care and treatment to those who are positive, so they can be linked to treatment as soon as possible, and those who are at risk linked to prevention services as soon as possible. Next slide. So now what I'd like to do is to look at some of the things we're doing at the federal level to address HIV inequalities. As mentioned, we sit in the Office of Infectious Disease and HIV/AIDS Policy, OIDP, that really serves as a coordinator of all of these different HHS agencies that are supporting our partners in the HIV epidemic. Next slide. In a previous slide, I briefly touched on a few tools we have in the toolbox to end HIV. I wanted to discuss one of these effective tools to prevent HIV, which is pre-exposure prophylaxis. PrEP are for those who are HIV negative and at risk for HIV. One thing we have done within HHS is to start a national PrEP program known as Ready, Set, PrEP. The Ready, Set, PrEP campaign, PrEP is a medication when taken effectively can reduce risk for those getting HIV by 99%. And the medication is so simple and easy to take. We have two medications, Truvada and Descovy. Descovy is currently not recommended for cisgender women, but Truvada is. But those two medications available can reduce the risk of HIV for those who are at risk. Next slide. Although we have these two powerful tools in the fight to end the HIV epidemic, communities that can benefit are not taking advantage. Currently, we are seeing is HIV prevention medication is underutilized. The latest published estimates show more than 1 million people could benefit from PrEP, but only about 10% are prescribed it. Communities of color are most impacted. Only 18% of people who could benefit from HIV pre-exposure prophylaxis, PrEP, are receiving it. African Americans and Latinx people are more likely to acquire HIV and less likely to receive PrEP than white. Next slide. So back to our Ready, Set, PrEP campaign. Ready, Set, PrEP is a nationwide program led by the U.S. Department of Health and Human Services, HHS, and was launched on December 3rd, 2019. The Ready, Set, PrEP program provides PrEP medication at no cost to thousands of individuals who qualify. It not only removes cost barriers, but also increases PrEP medication nationwide. It was developed to really increase PrEP uptake among those communities most impacted, such as MSM, Black, African American, Hispanic, Latinx, and Indigenous communities. It is a program for those who are uninsured or underinsured. To be eligible, one must have a negative HIV test, a valid prescription, and no prescription health coverage. I want to point out that you don't have to be a healthcare provider or a PrEP provider to enroll someone in Ready Set PrEP. Anyone can, and it takes less than 5 minutes. In addition to the Ready Set PrEP program, it's open to everyone, including those without citizenship status, as long as they meet the 3 criteria mentioned. Minors can also utilize the program as long as they are not under their parents' insurance. Next slide. The exciting part about the Ready Set PrEP program is that individuals can pick up their prescriptions at more than 32,000 pharmacies across the US. You can find a list of those pharmacies and locations on getyourprep.com or hiv.gov. We have worked with many commercial pharmacists across the US, including DC and Puerto Rico, to be able to provide medications through many commercial pharmacy networks. The reality is people have more access to a pharmacy than a provider. We continue to expand the network and make it more accessible and convenient to individuals. These pharmacy partners have donated their services to distribute PrEP at no cost, including free mail orders, and provide patients with counseling to increase adherence and no additional cost. Beginning this year, individuals are now able to receive their prescriptions in the mail without having to go to one of those participating pharmacies. They can get their PrEP mailed directly to their homes or health center or any other location they prefer. Next slide. To increase access to PrEP medication and increase enrollments in Ready Set PrEP, HHS launched I'm Ready, a campaign with real people, real voices sharing what it means to be on PrEP, with the goal to increase uptake of PrEP by helping to eliminate stigma. We know HIV has no demographic barriers. The campaign features Black women, trans women, and Black, Latinx, and Native men sharing their stories in both English and in Spanish. The campaign uses narrative storytelling and engaging videos to share stories of real people sharing their personal journeys with PrEP. Next slide.
So Alberto, in the interest of time, I'll play one video because we're behind time. That's okay. Okay, I'll play the Spanish video.
Okay.
This is an example of our campaign.
Soy nacido y criado en Puerto Rico. Culturalmente tenemos que lidiar mucho con esta idea de esa internalización, de ese estigma por mi sexualidad. PrEP logra romper con esas barreras y decir, podemos proteger nuestros cuerpos, podemos proteger a nuestros compañeros sexuales y también podemos acabar la epidemia del VIH. Nosotros podemos cambiar la narrativa. Mi nombre es Damián, yo tomo PrEP y estoy listo para prevenir el VIH.
Okay, thank you, Michelle. So that's just one of the videos, and there are several others, of course, on hiv.gov with additional resources, banners, posters, and other material you can use. Another campaign that we're getting ready to launch is the virus suppression campaign that really prioritizes and targets those communities most impacted. The goal of this campaign is to increase awareness and encourage the virus separate strategies and messaging as an essential component of ending the HIV epidemic. Next slide. There are also funding opportunities for those of you who are interested in this work through the Minority HIV/AIDS Fund housed within OIDP. We have been implementing strategies to engage all levels of partners to address HIV inequalities and disparities among minority communities. Some examples would be addressing stigma or addressing medical mistrust. Next slide. In August of this year, OIDP launched America's HIV Epidemic Analysis Dashboard to be able to visualize the NHIV data to all of our stakeholders, including the public, to know where we are in our efforts with ending the HIV epidemic. Now we can look at things through different social determinants of health by race, ethnicity, and age. We can also stratify this data. Next slide. This is a snippet of stratified data from the AHEAD dashboard. This is looking at data between Arizona and Maricopa County. The goal here is to decrease the number of confirmed HIV diagnoses by the goal year. In the state of Arizona, we can see an increase among those 55 and older. However, when we look at Maricopa County, we see those between 25 and 34 are most impacted. Let's look at one more snippet from the AHEAD dashboard on the next slide, please. So looking at race and ethnicity, Arizona versus Maricopa County, diagnosis in the state as a whole is decreasing among Hispanic and Latinx, Black and African Americans, and increasing among whites. However, when we look at Maricopa, we see Hispanic, Latinx, and whites are the groups most impacted. Next slide. In 2021, the first ever national plan to address sexually transmitted infections was released, really focusing on communities most impacted and addressing inequalities. This is very exciting because the first ever 5-year plan that aims to reduce the rise in STIs in the United States. The plan provides a roadmap for a broad range of our stakeholders, including public health, healthcare, government, and academics, to provide and enhance, expand STI prevention and care programs at the local, state, tribal, and national levels. STIs are risk factors for HIV. Next slide. In Maricopa County, syphilis and congenital syphilis is very high. It's important to see the intersectionality with STIs and HIV. And when we look at HIV, we must also look at STIs. We know here in Arizona, syphilis is on the rise. From the graph, we can see there are disparities in syphilis cases among American Indians with the highest number of cases. With that, I'll turn it over to Michelle to continue our presentation.
Thanks, Alberto, for the introduction. So hi, everyone. Happy to be here. So I want to take the next few minutes, because I know we're behind time, to talk about what does this all mean at the federal level, and really take a little deeper dive of how we are prioritizing everything we do across the federal government, not only HHS, through a health equity lens. So we had the opportunity to learn about the initiative that's been going on to its second year already, and really hear how our office is working to address these HIV inequalities that Alberto mentioned, right? So I want to just highlight one thing that Alberto mentioned. The initiative started under the previous administration in 2019, but I'm very excited to announce that under the current administration, Biden-Harris administration, they 100% support us ending the HIV epidemic, because again, we have the tools today to end HIV, as Alberto mentioned. However, they want us to do it a little differently. They want us to continue to accelerate and strengthen these efforts by providing all of our partners with the resources they need. But most importantly, what I'm really excited about is that they're looking for us to address specifically how we unpack the health inequalities that we have seen for decades, right? I always like to say we're in the HIV field, Alberto and I, but you change the disease and it's still the same disparities, right? You can add hypertension, maternal mortality, diabetes. It's the same communities impacted. And we know that this has been happening for decades. So under the Biden administration, he has really prioritizing us looking at equality, specifically how we work to eliminate stigma, HIV stigma, discrimination, HIV criminalization, racism. Last summer, we heard loud and clear the civil arrests that we saw with police brutality. These are all things that really impact our communities, right? And the administration gets it, and they support it 100%. Also, most importantly, these are things that we've been hearing a lot, is addressing social determinants of health, right? How do we address those those environments that our communities are facing, communities of colors, to really unpack the inequalities that, frankly, again, we've seen for long decades and we have not been able to solve. So as part of the new administration's priority with looking at HIV through this health equity lens, I'm excited that our office is working with the newly reestablished White House Office of the National AIDS Policy to really look at how do we revise the guidance and the national plan that was released last December. So last December, we released what's called the National HIV/AIDS Strategy, which really is a roadmap for all of our stakeholders to look at how do we address HIV. So it goes hand in hand with the initiatives, right? The federal government likes to do all these different reports, so I get it, it's confusing, but they really want to be able to line things up. And again, we are so excited because in this new revised plan, we're really unpacking what we all need to do as a public health community to address HIV inequalities. Again, how do we address some of that stigma, discrimination, racism, homophobia, transphobia? Because that to me is what's killing our communities today. How do we expand access to care? And again, Alberto mentioned the intersectionalities, right? How do we address all these syndemics that are just causing these disparities? So it includes substance abuse, behavioral health, harm reduction. So within our office, a new Assistant Secretary for Health, Dr. Levine, who is the first transgender woman in that role, has really paved the way for us to look at syndemics, right? All of you are in the public health field. You all get what we need to do for equalities. And I know you're all working in different areas of health. So how do we look at these areas to really underline and address the inequalities we're seeing? So stay tuned for that. We're hoping to release it during World AIDS Day on December 1st. And I encourage you to go to hiv.gov for more information on that. So as you heard from Roberto, we know that HIV disproportionately impacts many of the same racial and ethnic groups, right? I know in Arizona, particularly in Maricopa, we see significant disparities among our Native American Alaska Natives and our Latinos, our Latinx communities. So on January 20th of 2021 of this year, President Biden signed an executive order to advance racial equity and support for underserved communities through the federal government. So what does this mean? So this basically means that everything we do at the federal level, not only HHS, I'm talking Department of Transportation, Department of Housing, Department of Education, Department of Agriculture, right? All these different departments, they have a duty on everything we do to advance racial inequalities and making sure everything they do is connected to supporting underserved communities. You can hear from my voice that this is a very exciting time because this will trickle down to the work you're all doing, not only at the state and local level, but at the grassroots level. We have support now from our leadership at the White House that we need to do something differently, innovative to address these inequalities. So in addition to the executive order signed by the Biden-Harris administration on equity, the HHS Office of Civil Rights prohibits and has came out loud and clear. It's been in place for decades, but they have put it at the top of the priority list that they will not accept sex discrimination, not only related to gender identity, but sexual orientation. And again, we know during the previous administration, we saw the discrimination on our gender identity, on our LGBTQ plus community, our trans community, right? Our non-binary. And we know that this all creates additional inequalities, particularly when we talk about HIV. So we're very excited that this is an opportunity for us to really look at not only at the federal level, but at our state and local level. How do we change these policies to be more gender friendly, to recognize people who are part of the LGBTQ community? Because as we saw from the data from Alberto, the ones being impacted by HIV are our MSM, Latino, and white community. And that should not be happening today, given the tools we have. So what do we mean by equity? You all are expert here. You're more an expert than Alberto and I. You know, this is, when we talk about equity, it's the core and the focus of the conference, which we're so excited to be a part of. But when we look at health equity at the administration level, it's really making sure that everyone has the opportunity to attain their full health potential and no one is disadvantaged from achieving their full potential, regardless of where you come from, regardless of your community. So we've just highlighted some of those communities at the federal level that we're really prioritizing. And again, I think this is the first time that we've added our LGBTQ plus community to really look at unpacking those inequalities. So again, you've heard me loud and clear. This really is an opportunity for us to change how we do business in our state, in our local health department, because now we have the support and the technical assistance hopefully coming in the next few weeks or months in December if Congress does approve the $68 million that are being allocated to end HIV. Again, the only way we're going to address inequality is by addressing those social determinants of health, right? I know it's a big buzzword when we talk about social determinants of health. What are social determinants of health, really? Those are those elements and those environmental factors that really impact us. We know where people live, where they work, where they play, where they workshop, where they eat really impacts your ability to access health services, right? And it really does impact your health outcomes. I mean, if we look at a few examples, we know that certain census tracts have higher rates of HIV, and many of those same neighborhoods also have fewer parks, fewer green spaces, fewer safe places to walk or exercise. They have a higher percent of fast food outlets, liquor stores, convenience stores. And most astonishing is that these same communities have a lower life expectancy than others. So again, I say that because we take away HIV, we add diabetes, and we see the same disparities. And we have not been able to solve that. So we're very committed in addressing those social determinants of health. You know, advancing racial equity and support for underserved communities really requires us to look at strategies that not only impact both the individual, but the community, right? When we talk about social determinants. So we have to really think about how do we create holistic interventions and strategies that address inequalities, looking at the entire community, right? When we talk about medical mistrust, when we talk about the misinformation we're seeing with the COVID vaccine, how do we implement strategies to address that medical mistrust, to address access to health services? These are things that we really need to look at. And it really is us being innovative and partnering with non-traditional partners, just like we're trying to do at the federal level, right? We're trying to work really closely with HUD, with Veterans Affairs, with Department of Agriculture to really unpack those inequalities we're seeing when we talk about ending the HIV epidemic. And then I wanted to I know we have a couple more minutes, but I wanted to take an opportunity to highlight the resource that Alberto mentioned, the AHEAD dashboard. This is such a great tool. It's not only a tool to be able to track and be transparent where we are with ending the HIV epidemic, but most exciting, it's an opportunity for us to really examine social determinants of health. Sometimes it's very confusing because we pull information from different websites, from the census. The AHEAD dashboard really is a one-stop shop. It really highlights not only HIV data, looking at those 4 pillars on it. Are we testing enough people? Are we getting people on PrEP? But it really allows us to look at those indicators that really impact social determinants of health. So I have an example here, and this was literally just a snip that I took from our dashboard, highlighting the entire state of Arizona. And we can look at, let's take unemployment, for example. We can see that the unemployment rate in Arizona is higher than the national average. This is for the entire state. And we know that unemployment is heavily associated with higher levels of new diagnoses and higher levels of individuals being connected to care and being virally suppressed. And we heard from Alberto the importance of making sure people not only are linked to care, but stay in care, because that is how we're going to end HIV. If I'm HIV positive and I have relationships with my partners unprotected, but I'm on my medication, taking my medication, I'm not going to pass that on. So that really is a game changer. But again, we cannot do that if we have individuals who are unemployed, if we still have gap wages, right? People who are working in the field, but perhaps are not getting what they deserve. And then also if they're in poverty. So these are things that we need to look at as a community to address inequalities. And this next slide highlights data from Maricopa County. Maricopa County is unique, right? I think we have about 1 million people there. It's the most populated county out of the total 14 counties. So when we compare the unemployment rate in Maricopa with the entire state, we see that the rate is even higher in Maricopa, which we would expect, right? Because it has the most people. However, it is in an urban metropolitan area. So when we compare it to the entire state, we see that there are also more individuals who are uninsured. All of those factors contribute to the many disparities that we're seeing today in our communities. So this is my second to last slide. So what does this all mean, right? What is our call of action based on the information that we shared to you today? Well, here are just some recommendations and things that we are hoping that all of you can think about and explore. And we ask for your feedback too, to be able to not only address HIV inequalities, but all inequalities, because the reality is, again, if you change the disease, the inequality still exists. So some of the things we have to do is we really need to think about how do we realign funding to communities most in need, to those communities that really have a pulse of the community, right? A lot of times we tend to fund these bigger organizations that have the capacity, but they might not have that pulse of that community. How do we provide culturally linguistic appropriate services that are patient-centered, but also easily accessible to all individuals, making sure we increase health literacy at all levels, because we want to be able to make sure our communities understand the information. Again, look at what we're seeing with the COVID vaccine. We want to have a better understanding of social determinants of health that are impacting individuals. This includes acknowledging and addressing stigma, discrimination, again, as we've seen with the COVID vaccine. And then how can we develop new interprofessional, and interdisciplinary partners to address issues such as employment, food insecurity, and housing? And I know that the Department of Health is doing some amazing work working with some of those non-traditional partners when they try to unpack some of those disparities in those chronic disease areas. So again, this can include working with the Department of Education or the Department of Labor with Access there. And I know that Access is doing many things with ADHS. Also consider using different funding streams to support intersectional issues such as, Alberto mentioned the STI crisis, the housing crisis, right? How do we get creative with our funding? I know sometimes funding coming from the federal government is very prescribed, but I'll tell you that we are really looking at how do we create more flexibility so you all can use that funding to be more flexible and share it maybe with different sectors to be able to address some of these inequalities. And then to me, most importantly, how can we make sure that we hire communities with lived experiences? Individuals who are currently living with HIV that look like our trans community, that look like our communities of color, because again, the reality is when you go see a provider, you connect more with someone that can understand your language and looks like you. So we have to do a better job creating pipelines and opportunity for leadership roles for individuals who really understand the community. And then lastly, data. Right? We know that unfortunately, there are many gaps and challenges with limited data. We don't have really good data to really unpack what homelessness looks like, right? What poverty, what trauma looks like. So those are things that we really need to focus on improving data. And then I wanted to just lastly share that ending the HIV epidemic is a whole of society initiative where we really are looking to have a collective impact across many different sectors. This includes the business community, the private community, the education community. So we have to be innovative and create and strengthen those partnerships to be able to address some of those inequalities that we've been seeing for decades. And I think now is the time with the leadership in DC that we need to get moving and do something differently. So that was a lot of information within 45 minutes. We did want to see some time for questions and answer, but I see that we're over time almost. But here's our contact information. Alberto and I physically sit in Los Angeles, California, but our sole purpose in our job is to support our partners in Arizona, particularly in Maricopa, and also California and Nevada, because those are areas that we know are most impacted by HIV. So other than that, I'll stop there. And Rogelio, I don't know if we have some time for some questions and answers, and maybe I'll stop sharing my screen here.
Yeah, absolutely. So I wanted to go ahead and share. Well, first of all, thank you to our presenters, and then thank you to everyone that joined us this session. I do want to mention that I did throw in the evaluation form into the chat. So please take a couple of minutes and fill out that evaluation. But then also, yes, the official time of the session has ended. However, this room will remain open for the next 15 minutes. If you have questions, if you would like to have any discussions with any others in the session, you can unmute yourself. You can also turn on your video if you'd like, and you can have an actual conversation. So again, thank you to everyone who participated in the session, and feel free to hang out for the next 15 minutes if you'd like before the next session starts. Thank you.
So Rogelio, I did want to I know there's been some questions on PrEP, and I know we have a few individuals. So, PrEP has been around not for a very long time, I would say since 2017. And PrEP is for individuals who are engaging in high risk behaviors, right? So having unprotected sexual relationships and injection drug users. And I will say, there are individuals who've been on PrEP for years since it first became available. So it is safe. The other thing is when you are on PrEP, you have to see a provider every 6 months because they need to make sure it's not impacting, your liver or your organs, because then there are different doses. But the recommendation is if someone is engaging in high risk behavior, they recommend that they stay on PrEP. Again, it's like taking a birth control pill, right? When you stop taking your birth control one day, boom, you can get pregnant the next day. So it's the same concept. And we also want to try to really normalize PrEP among our heterosexual women, particularly women of color, Black, African-American, and Latino women, because that is where we're seeing HIV on the rise. The one thing I will mention, Alberto talked about the HIV outbreak, the largest urban HIV outbreak we had in Indiana back in 2015. Do you know how the first case was identified out of those 200 plus individuals? It was identified through an OBGYN visit. Someone went in for prenatal care 6 months into their pregnancy, got an HIV tested positive, started asking questions, and they found out that this rural community in Indiana were all linked through injection drug use. Over 200 and something individuals were HIV positive. So again, we need to be able to address some of those missed opportunities and normalize that PrEP is like a birth control pill and do a better job promoting it with women of color. So I hope that answered the question that you had about PrEP, but I encourage you to go on hiv.gov. Alberto mentioned the campaign that we just rolled out called I'm Ready, Estoy Listo, which again highlights real individuals, not actors, that are on PrEP. They talk about their story, how it's empowered them. So we do have a Black cisgender woman talking about her experience, because that is where we're seeing the epidemic right now among our Black heterosexual women and Latino women. So we all need to do a better job to promote it. So if there are any other questions or comments, we're happy to stick around for a couple more minutes. I know it's your break.
I had a question about widespread use of the rapid start protocols of getting people on medication immediately rather than waiting, which has been the custom. Are you all tracking progress and changes in time to viral suppression nationally, or at least in your region at all?
Yes, that's such an important question. We are, and all of the counties that have been receiving funding for this whole initiative have been tasked and are required to report how long it's taking to link someone into care, because now the protocols, they have to be linked into care, if not right away, no more than 30 days, right? But also virally suppressed. That information is available, and it's something that we are tracking. And again, we are seeing disparities, not only with linking people, but also people who are virally suppressed. And I think it paints a story of some of those issues that we talked about around social determinants of health. So yes, absolutely. And it's also available in the AHEAD dashboard. So if you wanted to see how linkage to care and viral suppression is looking in Maricopa County and Arizona, that data is available, and it's also up at the ADHS website.
So do you know if somebody is tested and diagnosed positive in a setting that's not like a HIV or STD care setting, you know, so suppose they go in for something else, like and the person does the HIV test and test positive, but they themselves, the provider, don't know anything about HIV because it's not their specialty area. Do you know like how well we do with those kinds of providers having information about Rapid Start and about things available for HIV patients? And how that information is it disseminated, or is there a gap there that needs to be filled?
There's definitely a gap. I know a lot of the different jurisdictions, and in our office, we've prioritized in educating non-HIV providers. So that not only includes the physician, but nurses, the community health worker, the front desk person, because again, there have been a lot of missed opportunities where providers just, oh, I don't want to do an HIV test, then I'm going to be responsible. So we're really trying to enhance and provide resources like, look, you're not in this alone. There's this warm hand on community organizations. This is what they do. I will say in Maricopa County, one of their priorities under their initiative is to build capacity with non-HIV providers to do exactly what you mentioned, to address that gap, because unfortunately there is, but that's something that needs to be addressed if we want to end HIV.
Are there models for other counties that you know of that?
Yes, there is. There are many different best practices that we've highlighted, and we're happy to share them. But also if you go on hiv.gov and the AHEAD dashboard also. And I will say to put a plug for Maricopa County, they're really focusing. They've also developed, not to get into the plan, they've developed on implementing like a learning collaborative for providers through the AIDS Education Training Center, which they're located in Tucson. But yeah, a lot of the focus is around exactly what you mentioned. And a lot of the focus is really educating the non-HIV community, right? Like the community health centers to really get people tested, get them into treatment if they're positive, or get them on prevention if they would benefit.
Okay. Thank you.
You're welcome.
Okay, my question is, I have actually two questions. You know, this PrEP, where's the place for because I know initially they used a drug to reduce the load of the virus. That's what they usually use before, you know, in managing HIV patients. They usually give them drugs to reduce the load. So with this PrEP, are they still using the drug, or, you know, is it in combination with that drug, or it has been eliminated and the PrEP is what is being used right now? Then another question I have is, you know, you said the HIV rate is higher among the Blacks and Latinos. Why is it like that?
Thank you. You know, your second question would probably take a whole long hours. You know, I could talk about historical trauma and all that, but let me answer the first question. So PrEP is a prevention method. So it's actually for individuals who are HIV negative. For example, I'm HIV negative, so I can take PrEP. So one of the requirements for being on PrEP is you have to have an HIV negative test, and you actually get tested every 6 months, right? And they check your blood, make sure it's not impacting you, because we do know that some do get side effects. That's number one. And then number two, you mentioned about the viral suppression load correctly. Someone who is, if I was HIV positive and my viral suppression load was controlled, and I get an HIV test, you can no longer find the HIV in my body. And I can still have engage in unsafe sex with my partner. Maybe I'm married and they will not get HIV. It's 100% effective. So it's this whole concept of U equals U, untransmittable equals undetectable. So again, PrEP is for those who are not HIV, to prevent them from becoming HIV. And I do know that there have been individuals who have been on PrEP for years, 5-6 years, and they don't have side effects, but some do. The other thing is we also have PEP, which we didn't mention. PEP is for an individual that perhaps maybe had an interesting night, had too much fun, and they engage in unprotected sexual, intercourse. So what they do is within 72 hours, they take 2 pills, which is same medication. I'm not a pharmacist, but same pharmaceutical as the PrEP, and it prevents the transmission of HIV. We don't encourage people. Some people, it's just like the plan B for birth control, right? If you have an accident, you can take it. Same concept. So I'm hoping that answers your question. If not, we'd be happy to send more information. And then your question about the disparities with our Latinx and our Black African American community. There's so many underlining factors that I think really contribute why we've been seeing those disparities, and we continue. I mentioned a little bit, just we haven't done we federal level have not done the job we need to reach those that are hardly reached. I like to say hardly reached, not can't be reached, right? But we see, as we see the epidemic today, it's on the rise among our Black and our Latinos, specifically our youth. The epidemic right now is on the rise between 22 to 32-year-olds. Those are individuals in their full capacity. So what are we doing wrong? What do we need to do differently? And again, to me, it goes back to the stigma. When we talk about culture, communities don't want to talk about it, right? So we are doing a lot of work with the faith community. We know faith and spirituality is important for our communities. There's been stuff done with like barbershops and stuff to really increase awareness. But again, we're here to learn from you all. You're the experts. What do we need to do differently? But we see the same patterns with other diseases, right? When we look at hypertension, diabetes, it's highest among our Black and our Latina and our Native American community. So why is there a pattern? And I think right now, although I sound like a broken record, it's an exciting time for us at the federal level.
It's very alarming, because when you look at the population, the Black population compared to, other population, or something like Latino compared to white and all that, the percentage is low compared to white. Then when you come to bad things, evil things, you see it, Blacks and, dominating in it. Why is this so? When you look at diabetes, high blood pressure, okay, now HIV, why is this so dominant in, among the Blacks? And then the Latinos, why will the evil things be dominant among the, this tiny population? Why? We need to start from there, because it doesn't just end, getting the treatments and all that. Why is this happening more here? Why? Certain things needs to be changed.
So I have 2 theories for your question, at least related to African Americans, actually African Americans and our Latino communities both. I think one is incarceration is a big factor. I think, I don't know how consistent we are with testing people going into prison and testing people coming out of prison. But also prevention through treatment has been a thing with HIV for some years. And I think that white men with health insurance and easy access to HIV care providers, meaning easy social access. I think because of stigma, Black and Latinx communities going to HIV providers is a little bit scarier than it is for a gay white male population that has been much more comfortable talking about this disease for 40 years now. And so I think they've been able to curb the spread there with treatment, with getting people on medication. And our communities are not doing that, on top of the incarceration rates and other things that keep people from getting to adequate health care. I think that's part of it.
Yeah, when you look at the data.
Oops, sorry, Michelle.
Sorry, go ahead. No, go ahead.
I was just going to say, with 30 seconds left, since I've been awfully quiet, I will say that what we're discussing, so like I'm in a position where I just bridge partnerships. That's all I do. And so working with kind of the traditional HIV institutions. So here I'm thinking of Aunt Rita's, and they are traditionally aligned with the white male gay community. And they are actively seeking to expand who feels they are accessible. And so one of the things that we've been trying to do is actually to partner them with groups that you wouldn't traditionally think about in terms of HIV care, but that reach other populations, just to start to have people moving through spaces and realizing that they can access this care and that they won't be stigmatized. It is accessible to them if they are, a woman of color in particular. So very interesting. I was just trying to be a fly on the wall as much as I could, but this directly linked back to conversations that I've had in the last week. And with that, I will excuse myself because I know that we're over time.
No, thank you so much. Like I said, these conversations are so important, but you have our contact information. The slides will be sent at the end. Feel free to use, disseminate. If there's any other resources, we're here to support. So I appreciate it. Thank you for staying.